we all get a different deck of cards. The law of large numbers says that we're not perfectly optimized, and that in some people, an unknown dose of lithium could potentially lower your risk of Alzheimer's and aging, and possibly a higher dose of lithium could allow you to be more emotionally stable.
Dr. Berner, welcome to the show.
Thank you.
Yeah, I'm excited to have you on the show because you have a lot of experience with one particular compound that has become quite popular over the last few years and months, and that's lithium. So, I'm really excited to dig into the research on lithium and your experience in your practice with it. So I think people have a very interesting show ahead of them. So maybe we can start with how did you, let's say, because you've been using lithium for a lot longer than it has become popular over the last few years. So how did you, discover lithium?
Well, lithium has been used as a mainstay in psychiatry for, decades and decades. And there's a fragment of the population that clearly should be on lithium in terms of a normative gain of function in the glycogen synthase kinase 3 beta pathway. And these are typically people with bipolar disorder. And you'll get arguments that are unanchored from solid epidemiology about what group of people should be on lithium and what dose. But we know about 1% of the population has bipolar 1, which is severe hospitalization, disability, suicide attempts. 3% of the population has mild form, where they occasionally miss work for weeks or months and make major financial or sexual indiscretions. And then there may be a much broader population, maybe as high as 10% of the population, who have very subtle forms of mood and energy instability that would clinically benefit from lithium, just in terms of their emotional stability. Well, this is a drug that has a very broad population indication in terms of mood disorder. And then when we move into the even broader distribution, which would be even at lower dosages, what percentage of the population would benefit in terms of aging and Alzheimer's prophylaxis, that hasn't been studied. We have very good, if you will, natural experiments in terms of random variations in the water supply, which, almost without exception, show increased longevity, decreased rates of dementia, suicide attempts, with even small dosages of lithium. So when you talk about lithium, it's not really a drug. The drug is irrelevant. What is, much more important for you and for your patients out there, not your patients, your podcast listeners, is just this concept of random assortment of 3 billion base pairs. And we all get a different deck of cards that is randomly distributed. And, the law of large numbers says that we're not perfectly optimized. And that in some people, an unknown dose of lithium could potentially lower your risk of Alzheimer's and aging. And possibly a higher dose of lithium could allow you to be more emotionally stable in a very broadly defined way. And we don't really have yet a technology to assay that deck of cards, the 3 billion base pairs that you get from the parents, right? In terms of giving each individual person, what is the right dose of lithium for me? And this is a critical issue in community health and in your own personal, decision about, what do I put into my body that is going to help me optimize my lifespan, health span over a lifetime.
Yeah. You were referring to the idea that lithium has been used for bipolar disorder for a long time, and quite not recently, but it has also been seen to be potentially useful for Alzheimer's. So there's actually one study this year that claimed that lithium deficiency was a driver of Alzheimer's disease, which makes it quite interesting for just general longevity and preventing dementia and neurodegeneration overall, beyond just bipolar disorder and similar conditions. So what do you think is the reason for that? So first of all, why does lithium help with, let's say, mood disorders and bipolar disorder? And what are those mechanisms that could also have benefits on Alzheimer's and neurodegeneration?
Right. So, biology is an engineering problem, and one of the reasons I'm excited to talk to you is as someone who's interested in anthropology rather than psychology, is the concept that human behavior is determined by evolutionary constraints, not so much by, verbal concepts and, self-image and self-esteem sort of things. But, we have this 3-pound brain that has unbelievably difficult energy constraints, on all sorts of multiple timescales. And so when evolution designs the system, it has to optimize inefficiently, right? And so I think you've talked about this issue between the persistent predator, that's skinny and sweats easily, in equatorial Africa, and a different population that stores fat well in areas with lots of seasonality. And this is fundamental to biology and fundamental to psychiatry, that we live in this world of trade-offs. We swim in a genetic river and we don't even realize the river we're swimming in sometimes until a wave blows us up and we can see landmarks. So I'm getting to my point, which is, there's trade-offs between growth and specialization. And in biology, we use the distinction between the mTORC1 pathway, which monitors the internal energetic status of the cell. How much protein is available, how much ATP is available. That's mTORC1, and that determines cell growth. And then we have a different pathway, the mTORC2, which is monitoring the signals from the external environment and determines how much a cell differentiates. And these are fundamental trade-offs, and Otto Warburg won the Nobel Prize for this in 1923, saying that we can use glucose for growth, the mTORC1 pathway, right? Or you can use glucose for action, to make ATP to run a cell at high speed. And these are fundamental trade-offs, right? And so when you give a patient lithium, or when you're taking lithium, maybe for age-related prophylaxis, the current scientific model would argue that you're mildly downregulating mTORC2, which is the activity pathway. You're telling your nerve cells to fire slightly less hard. You're telling your astroglia to produce food and cholesterol to the nerve cells slightly less aggressively. You may be telling the microglia that are pruning your cells, maybe you need to not prune 8 hours a night, but prune 6 hours a night. And, maybe the metaphorical concept is that when a cell is overdriven, it tends to decrease its natural rates of autophagy and decrease its natural rates of mitophagy. It lowers its maintenance cycle. And so it tends to die in a more senescent way. Okay? It may prune its mitochondrial population less aggressively. In other words, you get less mitophagy. There's all these sort of postulated downstream mechanisms of unknown weight, but I think for people who are diving into biology and just getting overwhelmed with all these different pathways, supplements, and arguments about this and that chemical, you have to go back to the basics, which is there's a fundamental difference between a Chihuahua, that lives 13 years and is really dumb, right, and a Rottweiler that lives 8 years and dies young, but when they bite you, they've thought about it, right?
Mm.
It's not the yippy kind of small brain dog that gets you. And these trade-offs are true in humans. I mean, they're everywhere. We can't escape our biology.
Yeah. Yeah. So the lithium then, so you said it suppresses mTOR-C2, which then has a downstream effect in increasing autophagy, if I'm not mistaken, that supports this cell recycling.
Yeah, I'm not sure I have it correct. I mean, the biological pathways associated with uh, suppressing GSK3B are so many, that it's easy to make correlations with anything, right? And especially if you're doing this in a dish, right?
Mm.
Because cells differentiate in different ways, So, for instance, in the kidney, uses glutamine as its primary fuel. The the intestinal mucosa may use butyrate. The nerve cell synapses tend to use lactate and glucose. The muscles use free fatty acids. So when we talk about using a metabolic drug like lithium, it's going to have different effects in different cells in the body. Now, what seems to be interesting in terms of decades of use of lithium, decades over millions of people, that it appears to target astroglia more than other cells in the body. And why do we know that? I mean, we know that because at low dosages, you don't really see a lot of changes in gross chemistries or in other organ systems, other than just in the variance in cognition and mood, right? And it's probably an astroglia target. That's what I would suspect.
I want to take a quick break to let you know about my favorite wellness devices, which are the bond charge red light therapy devices. You've probably seen many of your favorite longevity influencers using these red light therapy devices, but do they actually work? Yes, they do. Red light therapy has been shown to have many benefits on skin anti-aging, hormone optimization, pain management, and even exercise performance. I use my device every day for 15 minutes, especially during the winter months when there's not much sunlight. It increases my energy in the morning and makes my skin glow. Just check out the testimonials on the bond charge website for the before and after pictures of other people. Most red light therapy devices don't have the right wavelengths of light, which might mean you're not getting the claimed benefits. Bond Charge uses the exact wavelengths of light used in research, and they also have near-infrared light that's beneficial to the joints. Head over to bondcharge.com and use the code SIIM, S-I-I-M, for a 15% discount.
I mentioned the earlier study, this 2025 study that claimed that lithium deficiency was a driver of neurodegeneration. That was in like animals. What's the human evidence for lithium in dementia or Alzheimer's?
Oh,
There are
okay.
Yeah.
What's our human data?
Yeah.
I think where I really got excited about this is, it was a while ago, maybe 8 years ago. I think Martin Scharf from Karolinska showed us some of his data at conference, where he looked at telomeres in patients on lithium and their unaffected relatives, right? So, and he showed that when he took patients with bipolar disorder and he put them on lithium, within 6 months, they had longer telomeres. And their telomeres were actually, I think, longer than their unaffected relatives. And I think that's consistent with what we see in the medical concept of bipolar disorder. It's not a disease of the brain. It's a disease of every cell in the body. And when I saw that data, I went to Matt Kaberlin's office and I said, "Hey, Matt, we actually have a biomarker, showing that lithium can make you younger. Is there any venue for us to, not so much start a business, but start an organization so we can leverage this data a little bit more aggressively?" That's a major breakthrough. And neither he and I were in a position to do this sorts of this stuff. We don't have a entrepreneurial brilliance, to set up a company like this. So there's data with telomeres. There's data with less atrophy on MRI. I mean, there's a famous study looking at atrophy and mood disorder. The idea was that, if you're depressed, are you going to have more atrophy with age? And the radiologist looked through these MRIs blindly and they saw these nice big plump MRIs. And oh my gosh, the people that had the young MRIs were the patients on lithium, right? And there's data from the UK Biobank looking at people on lithium have remarkably decreased rates of instant mortality relative to patients with mood disorders on other drugs. There's epidemiological data, looking at natural variations in the water supply. I think we published a case report showing reversal of some of the serum dementia markers within 3 months. Brazilians have a double-blind study looking at Alzheimer's with lithium. There's a lot of human data. It's not hard to find. The difference with the recent Nature study that was looking at lithium is it was Harvard and it was in Nature. Right. So it really wasn't that unusual to see this result. Everybody knew they were going to find it. Right. Yeah. What was different is they had enough money to do, RNA analysis and try to do some of the basic, RNA analysis and look at some of the pathways and then drive the science forward in a more incremental and very technical way. But there was nothing surprising about that paper. It just is, what happens in science. Stuff happens in the fringes, and then the major journals just replicate what everybody already knows.
Yeah, it got more attention. Just, gotcha. So the water supply thing is quite interesting. That areas with more lithium in the drinking water have lower rates of suicide, lower homicide, and just greater longevity overall. And you can see that in different parts of the world, like Texas, Japan, Lithuania, a few other places. So it's it increases the likelihood that it is the lithium specifically in those areas that is responsible for some of those benefits. So lithium is a naturally occurring mineral, but with many minerals there can be, or there is the risk that in very high amounts it can be harmful. So what is the sweet spot for lithium? That
your listeners might find this interesting. I just found it hilarious. Like a couple of years ago, there was an article in a public health journal saying that we need to put lithium in the water supply. And if you read the article, they said, we'll try to get this done with a democratic process, but if the public resists us, we'll do it anyway. So, just for the paranoid people out there, you better be careful because you may be ingesting more lithium, whether you like it or not. If we get too much excitement about lithium.
Yeah, but I mean, maybe then people will be happier, they have better mood and less...
they won't revolt against the public health establishment if they're stated on lithium.
Yeah. But yeah, obviously excess lithium could be harmful, and it appears that most people might be not deficient in lithium, but they could benefit from some small amounts of lithium, maybe from the drinking water or from some supplements. So yeah, what do you think about the dose? Because I've seen that, these recreational users of lithium, they use something like 1 milligram of lithium per day. And the bipolar disorder doses are significantly higher, like hundreds of milligrams. So what do you think is what do you think about the dose?
Um, when I've been giving talks on lithium on these podcasts, everybody keeps, asking me, "Hey, you're the expert. What's the appropriate dose?" And the answer is we don't know. We don't have an aggregate dose, right? Because lithium is clearly going to make some people worse. Okay, we know this. Okay, this is absolutely certain, right? Promislow looked at different species of Drosophila and looked at caloric restriction across species. And he showed that caloric restriction decreased lifespan in about 10 to 15% of Drosophila. But it massively increased lifespan in the other 85%. So the net benefit is like, oh, caloric restriction is good for everybody. That's scientifically false. Okay, it's false. That everybody should pursue caloric restriction as a longevity agent. And it's scientifically false that most people would benefit from lithium. That's just an unsupported statement. Okay? It may be in the aggregate that there is a substantial portion of the population that would benefit from lithium. And we should proceed this with all due and aggressive speed, right? But we don't have the knowledge to tell an individual patient, what dose of lithium is right for you. Now, I am going to address this topic, and I'll try, if you give me a few minutes, about what the alternative is, which is the N=1 trial. That I think a lot of the biohackers are very appropriately trying to do, which is to look at their own unique biochemistry and design their own program that's relevant to them rather than using aggregate data, right? And what would that mean? I think that would mean that if you were interested in a drug like lithium, the very first thing you would do is just say, hey, what are my biomarkers? What am I expecting to make better, or what am I expecting to make worse? And do I have a cost function that would let me decide whether this was a good drug for me? Right. So, if you were worried, you say, you know what, I'm kind of a little bit on the bipolar side of things. I may not have a formal diagnosis, but my sex drive tends to be pretty high and variable, like you see in bipolar patients, as distinct from depressed patients. No sex drive defines the depressive syndrome. High sex drive, by definition, defines the bipolar side of things, right? The best way to make a male bipolar is to give super physiological testosterone. You can produce a bipolar syndrome in about 20% of men. You can drive them on the Gaussian by differentiating a cell too much with high levels of TORC2, which is the sex steroid. So for someone out there saying, hey, I wonder if lithium might be right for me, do you look for these soft markers of bipolar disorder, which is your sex drive tends to be high and variable. Right? Your activity level tends to be high and variable, right? You may have a higher IQ than normal. You may be in a family that has a dense history of mood disorder of any type, whether it be bipolar or depression, right? There are all these soft markers of bipolarity that might make an individual person be more or less inclined to consider that lithium is a reasonable agent for them out of just the immensity of all these agents that are supposed to make you live longer. I mean, there's so many now. I mean, you can't even possibly handle all the combinatorial trials, right? So I think that's even before you think about lithium dose, you just kind of try to think to yourself, what objective scientific data do I have as as distinct from checklists, which are useless. I mean, phenotypic checklists, they're low density information. That would suggest I might be somebody that has an overdriven TORC2 brain, that is running at very high rates at the limits of the available energy supply. So I often joke with my patients. I say, "Hey, you look like a normal person, but if I was a Peruvian Indian, opening up your skull, the smoke would come out, right? I mean, they'd be running really hot." And then, what dose you would use, there is no expert because this is a population distribution. And you can't look up some guideline from the Massachusetts General Institute of, Pharmacology, or American Psychiatric Association of Pharmacology, or, some institute of lifespan extension, because I don't think the data has been generated. In terms of the individual dose that's right for you, we just don't have that data. And you'll have to create a machine on your own to tell you what's the risk of benefit.
Yeah. So you're saying that people with more bipolar tendencies and mania and more like hyperactive brain, they would benefit more from lithium than people more on the depressed side.
And the risk is lower, right? So if you tend to have very mild mood instability, or emotional instability, or cognitive instability, energetic instability, whatever you call it, and you get a good response to lithium, you're going to get the responses that we see in the clear bipolar patient population. Is that lifespan increases for patients who are treated for bipolar disorder, not because of decreased suicide attempts, which is there, but things like decreased auto accidents. You look twice, pulling out of the driveway, right? Decreased use of recreational substances. You may be drinking 5 drinks a week rather than 15, right? Things like probably better control of your nutritional status. I mean, there's very clearly a group of bipolar patients. They're on their diet, they're on their exercise routine for 3 months, they lose 10, 15 pounds, they're super fit, and then they get a bipolar depression and everything falls apart and they start getting caloric craving and they move less and then they gain the weight back. And they just don't understand it because they're a high IQ person. And, why is it I can't keep my motivation stable? Right? Is that a marker of soft bipolarity? Right? And if it is, and drug like lithium, and I don't care about lithium. Lithium's just a tool, right? But it allows you to be more consistent over months and years in terms of your health maintenance schedule. That's probably a good thing. It allows you to use your other tools in terms of health maintenance, caloric restriction, exercise, sleep regulation, whatever thing you think is useful at a time, you're going to use that better. And so that's going to increase your lifespan. So just to summarize, I think the data with treating bipolar patients is that when your brain works better, the longevity implications may be downstream from health maintenance in general, rather than just preventing suicide attempts.
Yeah, gotcha. Yeah, because bipolar disorder patients have slightly unhealthier lifestyle habits, or at least they have bigger swings in the consistency with those habits. There's research that the lithium could also help with the tau protein in the brain with in Alzheimer's and neurodegeneration. So do you think, how big of a role does that have in longevity? And what do you think about lithium as a potential treatment for neurodegeneration?
There's been many people studying this, right? And from my perspective as a practicing psychiatrist over the last 30 years with more than 15,000 patients, I worry that these studies really haven't done dose finding very well, right? I mean, when you treat patients with bipolar disorder, you end up creating these very personal cocktails. Some people are on 1,200 of lithium, some people are on 150. When I'm treating people with very early Alzheimer's, defined by the ATN markers, tau and amyloid, NFL in the blood, you're not using those dosages. The patients don't tolerate those dosages. And the doses that people get benefit and risk from are highly variable, right? And so I worry when you do these academic studies where the dose finding is in a very restricted range, that we're missing, we're not doing these correctly. We need a biomarker that is cheap, accessible. Everybody agrees it's useful, and there's a consensus about its utility. And I don't know if the field is quite there yet. So in terms of serum biomarkers, there's still some arguments about the different tau species and which ones are better for Alzheimer's and which ones are better for different forms of dementia. And, it's moving so quickly that it's hard for even someone like me who's kind of in this area to keep track of it, let alone normal people just living their lives, wanting to be current with the state of longevity research.
Gotcha. There's also some evidence that it can be harmful for kidneys, lithium in large doses. So is that also something that is individual, or is there some threshold that you think exists?
That may be completely incorrect in the sense that it's been known for quite a long time. Maybe, I'm not arguing for sure, right? But it's been known for a long time that bipolar disorder is associated with accelerated rates of premature kidney failure, an age-related kidney failure. And so some of the studies, when they stratify bipolar patients maintained on monotherapy on agents other than lithium, find similar or higher rates with other agents. And so you may be seeing confounding by indication, this classic problem of wet roads cause rain rather than actual randomized studies. Now at higher doses, lithium is going to affect the kidneys preferentially to some degree because some of the kidney cells use glutamine as their preferred fuel, and lithium affects the glutamine homeostasis within the cell, and people will have some metabolic toxicity from lithium at an unknown dose, right? It's highly dependent on the patient, right? And so, they'll be urinating more, and they'll have a defect in free water retention in the kidney. And that's usually reversible, right? I think there are edge cases of lithium toxicity that have been reported, but in general, I'm not sure the science is very strong that lithium is causal in most cases of renal failure that you find in bipolar patients. This may have happened anyway.
Gotcha. Yeah. Obviously, I took lithium for a little while just as an experiment, just to see if I notice anything. I obviously took a very small dose. I took only the 1 milligram dose, and I didn't notice any. I measured my kidney markers as well, and didn't see any difference, which to be expected on a small dose. And in regards to the mood, then for what it's worth, I did experience maybe like a 5 to 10% increase in my mood. but that's very subjective and not very a scientific way to go about it. But yeah, that's just my own short experiment that I did. I actually did it like twice. Once a few months ago, and the first time I did it like several years ago. But have you like yourself tried to use lithium or microdose lithium?
Oh, for me?
Yeah,
Yeah.
just as an experiment.
No, because I don't have the time for it.
Mm.
I don't have a death neurosis. I mean, I'm not like horrifically fearful of dying,
Mm.
and I'm not seeing any, uh, reasons as yet to to the cost benefit of this experiment. If it turns out that I'm seeing early signs of brain instability, that's a different story. But there's a lot of things that people need to attend to in their life other than just living as long as they can. I mean, that's the trade-off between short-lived animals and long-lived animals. And again, it's a normative human variation, normative, right, to have more or less concern about longevity.
Mm.
And again, this is just a really important point. The longevity community is not normal.
Yeah.
They're not. I mean, we know
Yeah.
them. By definition, they have a different chemistry than the non-longevity community. And great, wonderful, right? But to expect that everybody is the same is one of these giant errors in when you do scientific studies. Right? We
Mm.
see this all the time in terms of drugs that have an effect size in a university setting and drugs that are used in the community. I mean, patients that tolerate university scientific protocols are weird, right?
Mhm.
Because they're so rude. I mean, they make the patient show up every week and you do all this laboratory draws and, they're very tight and demanding. And, normal people in my clinic are going to tolerate those sort of protocols.
Mm.
They want their healthcare like their food at a fast food restaurant, cheap, fast, and good.
Right.
Right. And so referral bias is really a problem when you try to
Mm.
extrapolate from these university studies.
Yeah. I get that's almost like a form of not selection bias, but kind of survivorship bias that the people who actually end up going through those studies are, already with certain characteristics that
100%.
may not be representative of the general population.
Right. And I think that's, the message to the longevity community. Be yourself, right? The very fact that you're interested in longevity makes you different than the regular population. You don't need to be the regular population. You have your own, unique humanity. You're going to have to invent your own protocols that are right for you rather than, this sort of average human, the conglomerate of everybody.
Mm.
Going back to the issue of checking your mood, the temporal lobe, which stores our episodic memories, it's not very well optimized to remember the moods from day to day, right? I mean, we go to
Mm.
bed and we forget our failures, and maybe to some degree we forget our successes, and we're a different person every night, in the morning after our microglia, digest our emotional experience from the day. And so it's pretty tough to know sometimes if you're getting a modest effect from a drug like lithium, because you're just not really optimized to remember your moods in granular detail from day to day.
Yeah.
It may be a more practical biomarker to look at things like the sleep quality, with high level actigraphy. And again, I don't know if there's a gold standard for that yet. I mean, you can do Fourier transforms on sleep, I suppose, and do some dimensionality reduction. But that's only one way of looking at this very complicated waveform. And maybe the longitudinal community is the people that need to do this, right? So there's data from UCLA, I think, that was replicated once, looking at predicting mood disorder course in 15-year-olds. And you could see from the sleep quality in 15-year-olds who was going to develop bipolar disorder 10 years later.
Well,
So you may not need to monitor your moods. If you're really disciplined and thoughtful about the way you look at your sleep quality with current wearables, that might be the kind of information that would make you a little bit more confident to go in one direction or another.
mm-hmm. Yeah, gotcha. But would prophylactic lithium use then be kind of useful in that scenario if you are noticing those things, or should someone then get like some more professional assessment? And I guess, yeah, is it safe then to take lithium, just recreationally over the counter, or would you need to consult with a psychiatrist?
Yeah, I'm going to kind of pass on that to some degree because I'm really not as deeply interested in lithium as I am deeply more interested in the concept of how does an intelligent and thoughtful person prepare themselves for the next generation of medicine, where your cocktail is highly personalized, right? And you're no longer shoved into these very broad categories with low information density. Oh, I have bipolar disorder. Oh, great. Thanks. That's 5% of the population. Oh, I have high blood pressure. Okay, thanks. That's 40 to 70. It depends on where people want to draw the cutoffs, right? You want to be able to discover your own unique chemistry, right? And what will likely happen in the future is, N=1 medicine where, maybe you look at your sleep quality and you compare your sleep quality to normative age-related decline. Normative. It's pathological, but it's normal, right? And you take a medication, whether it be lithium, a TORC2 inhibitor, or whether it be rapamycin, a TORC1 inhibitor, or, whether it be tamoxifen, which is a TORC2 inhibitor, or, whatever the drug of the moment is. And you compare the variance, the normative variance in whatever target molecule you're looking at, disturbances in sleep quality. And then you do dose titration and you say, hey, at what dose do I seem to look better and feel better? And then when I go too far, I tend to do worse. Right? I mean, it's highly empirical. It's perturbation.
Yeah.
And our regulatory agencies haven't really embraced this as a model of dose finding because it's too expensive. And because they just didn't think that way. It was always like, oh, there's a disease, you have it or you don't. Right. And biology just thinks that's ridiculous. I mean, it's a sign of a lack of training. If you see a physician and they think in that terms, they're bullying. Right. And so our regulatory agencies have to adapt to, the reality of the law of large numbers, that things are distributed on a gradient, with occasional incontinuities, but largely smooth surfaces. And as a patient or somebody who's interested in longevity, you have to say, okay, what biomarkers make sense for me, that I can gather at a reasonable cost and have a reasonable amount of reliability. And then now you're on your show right now and you're saying, hey, is this lithium something that is promising? It's absolutely promising. It's very promising. I think the more your readers look into us, they'll see, the conflicts of interest are very low, right? It's a generic drug. Nobody's making money off of it in general, right? So you're not going to have to wade through a lot of sociopathy, where the literature gets distorted by people lying to you in order to make money, or even for that matter, to pad their academic credentials, which is a problem, right? You can see a different level of sociopathy. But then the question goes back to, what is this dose right for me? And I can't advise you. We don't have the data for the individual person. You're going to have to scramble for that data on your own. And it would be nice if you could find a professional who's educated and sympathetic and has experience with using lithium. But there aren't a lot of people out there, who have the time. They're managing psychiatric patients. How do they move to the next level and manage a much larger population of people who just want to live longer? We're left with labor constraints that are not easily fixable.
Yeah. I guess, AI might have some role in making that task easier.
It's absolutely the role. It's the cure. I mean, we want to develop an AI program for this sort of thing, and I would develop it tomorrow if I had access to people commensurate with my level of skill in terms of managing large databases and doing multivariate optimization. But I can't compete with Meta or with Grok or with OpenAI for those sorts of people, right? They're busy building Elon's robots and, doing drone warfare. Right. So, how do someone like me, how do I get the capital and even more importantly, the intellectual talent to develop this kind of AI that is accessible to larger populations than people who live in my catchment area in Seattle? I mean, that's the technology. We need to do this. I mean, it needs to be done, right? But it's just basic economics, right? You have to have a big enough market out there, to drive capital development so that we're able to create this AI. And it has to be credible. It has to be branded. And people have to understand that the people who are making this AI are not crooks and are doing it to provide real value. And that's basic economics, and that's difficult. I mean, that's an intellectual exercise just as challenging as, understanding the basic source code of longevity. We're not going to get there just with scientists. We need brilliant business people, and we need them just as much as we need the scientists.
Yeah, absolutely. You've also written some papers about rapamycin, which, many people know as a potential longevity molecule as well. My question is, do you see any synergy between lithium and rapamycin or some other compounds? Because, rapamycin has a pretty big track record of life extension in animal species. Humans is, as I said, more limited. I would even argue that lithium has probably more longevity evidence in humans than rapamycin. But in animals, rapamycin has more evidence, in my opinion. So do you think they have some potential synergy between the two?
The answer is yes, of course. Right. And so the Drosophila, I think this has been done in a number of animal studies, right? Where they've added lithium to rapamycin in Drosophila, and they saw an extra 10% longevity. And then I think it was done in also a rodent model. I don't have that paper on hand, so I can't speak to that. Right. So for animals living in a cage, which is not humanity, right? And we don't know how they feel, right? There's no, biology doesn't care if you're happy, right? Biology just wants you to reproduce. Right. So when you ever see these longevity studies where animals are forced to take these drugs, are they living in a hell or are they living in heaven? We don't know the subjective experience, right? So you got to be a little careful about this stuff, right?
Yeah.
But there's absolutely animal data that suggests that you get an additive effect. In other words, they're not doing the same thing, right? Do I have clinical data on that? 100%. I mean, I have people on lithium and rapamycin, and they do better on the combination than they do alone. And they're not using it for longevity, at least not directly, right? But they're sick. And when you put the two together, they get much better outcomes. And then the question is well, who and what dose? I mean, it just goes back to the same old problem: patient selection and what's the dose. And if your listeners will forgive me, I mean, this is just, they'll forgive me for this. This is just simple linear algebra. What's the basis space, defined by the eigenvector of lithium and rapamycin response in a biochemical system? And then what's the eigenvalue, which is the dose for lithium and rapamycin, right? It's literally just linear algebra, where we're trying to define a location of a patient, or anyone for that matter, in a complicated n-dimensional biochemical space. And we can define a basis space in terms of lithium and rapamycin effects, if we have enough very smart people helping us get this data. But we have to scrape the data first, before we can develop the AI.
Yeah. Yeah, you mentioned the rats being happy and having no control over their in the experiment about what they're given. If you look at the movie The Matrix, then that's also like a possible scenario with AI, that the AI decides that this is the best dose for you for whatever it deems to be our goal, but we're living in like a matrix or some hell simulation. But obviously that would entail the AI actually becoming way more powerful than it is right now, which may not happen.
Well, no, I mean, it's this whole thing about AI taking over our world and stuff like that is complete nonsense, right? Because we've already gone through this transition, right? We have mitochondria that live in our body, right? And they were bacteria that became commensal, and they gave up control of their DNA to the larger organism in order to survive. And now we have a substantial fraction of our biomass is mitochondrial, and they no longer have autonomy. And that was a good trade-off because they're able to replicate their DNA better. Okay. We're already living in the world of AI. We're already living in the matrix. I mean, it's already too late. We're not virgins anymore, right? If the internet goes down, we have a massive, solar flare, and the internet goes down for 3 to 4 weeks. Half of, 2 billion people are going to starve to death. Right? We're already there, right? So the question is not whether or not we embrace AI in order to help us be happier, have better health span. Of course we're going to do it. I mean, it's silly to argue otherwise, right? More of the question is let's just do it right. Let's not have one person in control of all the resources come up with some vision of utopia and make all of us march in lockstep, but rather have an AI that is incredibly personalized, that's right for you and your family and the people you care about. And the signal is all local, and this is what happens in the mitochondria, right? The mitochondria DNA to some degree is selected for, either to grow or to be eliminated by mitophagy with local signals. So we want a diversity of thought. We don't want the pharma complex or the NIH or regulatory agencies, just coming up with these ideas about what's right for everybody. Right? And we see this in biology. Some species breed a lot and die young, and some species breed slowly and die late, right? Everything is related to sex and sexual selection at the end of the day, right? And we don't need one species of humans taking over and telling another subspecies of humans about what their values are and what they aren't, right?
Mm.
And I'm using species as an anthropologist would use it, right? Which is a species is defined as a population that breeds within itself, right? And humans clearly selectively breed, right? And that's obvious, right? And we just it should be very individual and very personal.
Mm. Yeah. You mentioned the mitochondria in a relationship between AI and humans. Which one is the mitochondria in that relationship, in your opinion?
Well, I mean, think about the advantages of silicon, right? We're stuck with carbon,
Right.
and we're stuck with our fuel supply eating. I mean, it's so pitiful. When you really
Right.
think about just how pitiful we are, we get. I mean, I don't know what the energetics are, but if you have something like rock and you have just like gigawatts of power, huge amounts of chip supply, of course AI is going to become better than we are at solving intellectual problems, right?
Mm.
But it doesn't matter because there's no selection pressure on. There's no meaning. There's no. There's no motivation for silicon, right? What drives the selection pressure is the survival pressures that have driven humanity, right? Starvation, predation, sexual competition, all of these things that as an anthropologist you think about and you understand how universal they are, where the psychologists are all thinking about, oh, how do I process information? We don't give a crap about it. We care about biological trade-offs. And we
Mm.
see the remnants of these biological trade-offs in the terms of mitochondrial selection, which I think, what is it, that we talk about in terms of exercise and mitochondrial quality control. The mitochondria fused with us years ago, but they still have the same selection pressures. They haven't completely gone away. There are mitochondrial cancers, right? These are the COX-negative muscle fibers, where the mitochondria still exist, but they don't actually produce any ATP. They just replicate themselves, right? That's a mitochondrial cancer. And if
Mm-hmm.
you increase if you increase PCG1 alpha, you increase these are these trade-offs that are just there everywhere.
Yeah. Yeah. Well, it's going to be very interesting for sure. And yeah, definitely looking forward to more studies on lithium as well. But as you said, there's already so much evidence that it has potential longevity benefits besides the brain benefits. But yeah, it's been great discussing with you. Before I'll ask my last question, where can people learn more about you and your work?
Well, I'm just a community psychiatrist, right? Who tries to keep my hand in. If you want to look at our papers on PubMed or Google Scholar, I think the last 5 years we've published in some very obscure journals, but it's very practical and it's dealing with real people, and I think I'm proud of the work. And if that's the kind of thing you'd like, take a look at it and see what's coming out. Hopefully, we'll have some new stuff coming out in the next couple of years, especially in the Alzheimer's treatment realm.
Yeah, so that sounds good. And my last question is, what's this one piece of advice or habit that you wish you adopted sooner?
Um, One of the psychologists who invented facial recognition scoring, became better and better at it every year. And he said, I became so good at it, I could tell when people were lying or not. Because not all of the facial movements are under voluntary control. Some are involuntary. So he said, and he actually like trained the CIA in how to pick out, who was lying or not. And so as he matured in his career, and he could see the lies that happened just even in small social interactions, like, hey, you want to come over to my house for dinner? And you say, oh no, I've got something else. He said, I realized how destructive it was to my relationship with people to lie. That we're social individuals, and communicating honestly and directly is the only way that we can have reciprocal connections that we can rely on. And so I think what I'm trying to do, especially in the recent years, watching the rise of medical tyranny, and I mean that precisely, where there are large organizations that control large amounts of money, and they want to control your life in terms of requiring healthcare payments, that it's just incredibly important to force yourself to be as honest as you possibly can, even if it's uncomfortable. It's the only way. It's the only way to live, because if you merge with dishonesty, it's hard to come back.
Yeah, there's a saying that in Estonia that lies have short feet, so they can't get far. So yeah, absolutely. Well, yeah, it's been very interesting and exciting, very thought-provoking discussion we had. So yeah, I'm definitely looking forward to your future papers and research.
Thank you very much. I appreciate the opportunity.
Yes, thank you.